Hello, this is the first of 5 presentations on material to help prepare operational leads to run projects that have a significant analytics portion. The goal of the class is to really support you as a leader at Lurie Children's in 3 ways: to clarify some confusing language around analytics that trips up a lot of people depending on what their background is, to make sure that your analytics efforts are really rooted in the processes of improving outcomes, services, and processes at the hospital. Sometimes that means doing clinical research or translational research. Sometimes it means doing quality improvement. Sometimes it means doing other kinds of analytic work, but to really make sure that we have the tools to root it in the process of improvement. And then finally, to give you the basic tools you need to manage those projects. Sometimes it's great to have a great analyst with you, but usually in addition to that, you need to have some sense of how to manage these projects. I think to give you a broader perspective, one of the things that we often think of is when we need analysis is we need a statistician and we need data. And really the purpose of the project manager or the operational lead is not to do the statistical work or get data, but it's really kind of to create a roadmap that the analyst will use to manage the analytic portion of a project. So if you think of the statistics and the data as being a car, the operational lead really needs to create a road and bridges and stop signs and all the kinds of things that an analyst needs in order to kind of find their way through to the other side and to provide the kind of support the project needs. So the first thing I want to talk about is the title of the course: Why do we think of analytics as practice? And so this course is really kind of committing to kind of 2 things. One is we're going to do a little bit of book learning, which is very typical for analytics. We're going to learn some discipline about how to use this book learning in practice, and we're going to get connected to some resources and learn how to pull resources from different parts of the hospital. So we'll for sure do some of that. But we're also going to do some really kind of deep practice and thinking about how to be open to the rigorous processes that analytics need. And also how to kind of develop analytics habits of mind. And so some of us have really kind of moved a fair way along this process, but it's relatively new for other people. So I tend to think of analytics as a practice because it's something that you don't really get good at by just the book learning and the discipline and getting access to resources. It's really something you have to repeat over and over and over again in many, many different situations. And then in time, you become sufficient. You feel like you have a lot of tools that are easily accessible to you and that work for you. And so the idea of this class is to introduce you to some of these tools, get you used to using them a little bit, and then to give you the foundation so that you can begin practicing analytics in your daily work life. So I wanted to introduce you to some of the analytics habits of mind. Some of these won't seem so different from what you might have been trained in other parts, in whatever discipline you're from, but some of them are things that we don't use every day in a really rigorous way. When I began graduate school, I had a professor, my first class, my first book we had to read. It's a really tough book for people to be introduced to. It's about design, research design, and methodology. And he said, once you've read this book, you'll never look at the world the same way. And he was right, because that book really established these really basic habits of mind that a researcher or anybody who wants to look at the world in an empirical way will use. So the first one is just being willing to set up unbiased tests, to be able to know that everybody in the room has a bias, and how do you set up a test to manage that bias. You can't get rid of it, but you just need to be aware of it and figure out how you're going to manage it through the analytic process. Challenging assumptions, that goes with the biases. Sometimes they're very biased assumptions. Sometimes they're just assumptions because we don't know enough. One of the things we like to do a lot in healthcare is alternate the frames of inquiry. We like to look at a problem from the perspective of a nurse, from the perspective of a provider, from the perspective of a parent, from the perspective of a patient. Really thinking about a problem from many, many different angles will often help us not only develop a better solution, but will also help us develop an analytical framework for addressing the problem that will be very useful. Being open to alternative explanations for why things happen. And then there's several other kind of tried into habits of mind that, that people develop once they've been doing analysis for quite some time. So why do we want to learn analytics practice now? Why is it so imperative that we think about it now? Well, healthcare, we know, is data rich. With the advent of the electronic health record and the expansion of the health record to include such pretty much all of care, so that so much of the care that a child needs, no matter what instrument it's recorded on, no matter what data system it goes into, somehow most of it feeds into the electronic health record. And there's a deep expectation that now that we have all these data, we can do something with them. So more data are available than ever before. I would say also, because the data are so complex, there's really limited access to the data. People don't understand how to use it. When they get it, it's hard to decipher. You would think that it would be, you enter something into a computer, you can pull that thing for analysis at some time, but it's really not that straightforward. It's actually quite difficult to do in many circumstances. And then I would also add that there is a general sense that the stakes are increasingly high when it comes to healthcare these days. There seems to be less resiliency in our systems. There doesn't seem to be the kind of error tolerance that there used to be, and it's not that we want to make errors, but there is this kind of tension that that data can kind of drive us to a kind of perfect world, and we need to get there, and we need to get there quickly. So there's a lot of stress around that. And then finally, there's just tons and tons of new analytical methods available. Some of them are absolutely tried and true, but many ones, we go to our conferences, we talk to our colleagues around the country, and we hear a lot of hype about analytic methods and how these tools are kind of unlocking us from problems we've had for a super long time. So I think that we're just in this stage where we have a lot of data. The expectations around data are very, very high, and the tools people need to have to use the data are not always accessible to people, and people often haven't even been trained on them. So one of the things that we like to think about in analytics a lot is this notion of a learning health system. Data dependency, really from the kind of the beginning of the EHR, there was a real sense that maybe we can in some place create not just a hospital with an EHR, but a system where constant learning goes on. And it's really fed by the EHR and its ability to pull data on typical patient care and exceptional patient care and feed it into a learning loop. I've heard descriptions of this that are pretty much, 24th century, that really the people think the learning will be kind of automated in a way. I don't see that happening right now, but there are lots of things we can do to create a learning health system. And in fact, I would say Lurie Children's in many respects already is a learning health system. And understanding how analytics and projects fit into the learning health system, I think, is key to us understanding how we can manage these tools better. So this is a diagram that comes from the National Health Service in England that lays out the components of a learning health system. And what I really like about this diagram is it really is very broad and makes it really clear how learning happens in organizations and what kind of supports need to be present in order for learning to happen. So the first one at the top is commitment and committed and respected leadership that engages the staff. That seems to be something that Lurie Children's does in a lot of ways. I've seen this acted out in a lot of ways. For instance, the Center for Excellence is often saying, if we want to solve a problem, we really need to talk to the frontline staff and get their input to solve the problem. So I feel like that's something that we're pretty good at. The second item is a culture hospitable and supportive of change. That's certainly an environment we live in. Whether we want to be hospitable and supportive of change, we don't have a choice. There's a lot of change going on, and we really need to support that. But I would say, in addition to that, I think our leadership understands that and wants to find ways to lead us through those changes. The third one is data analytics that measure and communicate impact, and that's what an analytic plan for a project would do, which is what we're going to be talking about in this series of 5 sessions. The fourth one is management practices that ensure execution and implementation. Over the last couple of years, the hospital has implemented the Enterprise Project Management Office and the annual work plan process in an effort to really peel apart, set our priorities, and help people navigate very large projects that touch many, many departments so we can be successful with them. Sixth is an enabling environment which supports and drives change. And so the EPMO would be part of that. I think a willingness on our information management's department to optimize EPIC to make it easier for clinicians to use it, I think is a great example of an enabling environment that supports change. The next is resources to support and do the work of change. This would be, for instance, the Center for Excellence and Data Analytics and Reporting. These are resources that are really there for people working on improvement projects and research, trying to find ways to move change forward and to improve all of our services and processes. And then finally, the capabilities and skills to identify and solve problems. And an example of this is the Center for Excellence's Improvement Scholars class, and when they're trying to teach people across the organization how to do improvement work in their own areas. So I think that there's a lot of ways in which Lurie Children's is already kind of living the learning health system, but there's also a lot more work to be done just because it's such a big endeavor. And so how do we get from where we are now to where we want to be as a learning health system and as a hospital providing high quality care for our patients and families? So healthcare is data rich. The reality is we're living in that. But in order to get to a learning health system kind of more richly than we are, we only have to do a couple more things, although they're big things. One is we just need to build on the strong background of research-based quantitative methods. Over the last 150 years, social sciences and behavioral sciences have developed a vast array of really strong quantitative methods that are really the foundation of not just research, but all of our quality improvement work, our program evaluation work, our return on investment work. Really wide range of work is really based on this strong background. So learning something about that backbone and how to use that backbone will really help us strengthen our projects. We need to value empiricism. We need to prefer empiricism over guessing about solutions. And so understanding that it's not just a matter of being data-driven, but it's really about asking the right questions and using good judgment in how we think through our problems. And then finally, really expanding the analytics know-how of our providers and staff so that when they're faced with a problem, they have some sense of how to use analytics to support their resolution, the way they solve the problem. So now I want to focus a little bit more on analytics in a learning health system specifically. At this hospital, we have really 3 streams of inquiry going on all the time. And these 3 streams of inquiry are really core to a learning health system. Figuring out how these 3 can work together and in a complementary way, I think is the kind of the trunk of the learning health system. So the first one is clinical and translational research, which we have a lot of going on at this hospital. There's a role as well for bench and basic research, but when we think about the learning health system in practice and what clinicians are experiencing day to day, we really tend to focus on clinical and translational research. That is, research that has direct bearing on how we provide services. The second one is quality improvement and process improvement. This is an area that's really grown in our hospital, both in scope and in sophistication. And this quality improvement and process improvement really just asks the basic question: how do we improve a particular service or process? How do we get it working better? It's a very kind of in the weeds, very straightforward, very kind of time and space limited work where you're really working on a particular workflow for a particular area and trying to help them get to a better place. And the third one is something we don't talk a lot about at this hospital, but really sews a lot of this stuff together, and it's called program evaluation. And that really asks a different question, although an overlapping question, to clinical and translational research and quality improvement. And that is, it says, how do we know we've made a difference in solving a real-world problem? So we put in a solution to problem. How do we know we're moving the needle on what we need to move the needle on? So as we think through what it takes to get to a learning health system and what role analytics has in this, we're constantly keeping these types of inquiry in mind, and understanding that all three of these have a very different role to play. And when we look at them, they're all really very similar. They're all modes of inquiry that take place in an applied action setting. They all take place in a clinic. They all are focused on outcomes and complexities around implementation, complexities about getting processes moving in the right way, complexities about training staff, and developing consensus about what is the best way to approach a problem. They all share a great deal. But it's important to understand that as they're sharing a great deal, they have some differences as well. So this diagram is a learning cycle. I could have put up like a PDSA, Plan, Do, Study, Act diagram that is very comfortable for people in quality improvement. I like this one because it emphasizes a couple of things that the Plan, Do, Study, Act doesn't emphasize explicitly. So what I'd like to do is just think about how, if you're a researcher, an evaluator, or a quality improvement person, you might go through this diagram in a very similar way. So for instance, but you might start in a different place. So a researcher might start by reading the research literature and asking the question, is this intervention that was done at this place, at CHOP or at Boston or at Seattle, is that something we could do here? That's the kind of question a translational researcher might ask. Or they might hear of some clinical tool that has not really been tried in a clinical setting and say, well, how would that work here? Quality improvement folks might be responding to complaints from patients or staff. Evaluation folks or quality improvement folks could be saying, hey, we're not meeting our benchmarks. How do we fix that? So it doesn't matter kind of what your motive is. It does, because it defines you as belonging to one of these specialties. But once you have discovered that problem, you really enter into the same learning cycle as the other two. So discovering the problem is just listening to the complaints, reading the literature, talking to your colleagues, looking at benchmarks. There could be other sources of learning discovering a problem in our own system in addition to those. But once you've discovered the problem, then it doesn't matter where you've discovered it from, the next stage is really defining the problem, getting clear on what the problem is in a very specific way. In other words, lots of times when we look at a benchmark, for instance, nationally, we might say, well, we want to be doing better on CLABSI. And so that's the problem. We're not doing as well as we'd like to do on something like CLABSI. So defining the problem is really the next step of saying, what does that really mean here? What does it mean we have to do? What are we not doing that other hospitals are doing? What are we not doing that could make us more successful? And getting really concrete about what those things are that really define and flesh out the problem and give us an anchor to move forward on. And then once we define the problem, we design a solution. In quality improvement, we're defining a process that's going to improve a workflow, for instance, or we might design a solution that would reduce practice variation. And then once we design a solution, we go towards implementing it. And as many people know who are operational leaders, the minute they design and start to implement, many things can go in an unexpected direction. And so one of the things I like about this particular diagram is it really pulls out implementation as a separate milestone in a project that you need to really think about, and that analytics can really help you with, but it's really its own stage, thinking about what can go wrong. And then once we've got a program implemented or an intervention implemented, then we go back and evaluate it and say, is this working the way we thought it would work? Is this having the outcomes we expect it to have? Are people liking it? Is it causing unexpected problems we didn't expect to see? And then sometimes we get to a point where well, we're pretty happy with it, but we need to fine tune and start the process over. And that's what this diagram describes. Now, having said all that, I think people who are leaders in this organization and any organization look at this and say that's an ideal situation, that it's very linear and that you go from one milestone in the learning cycle to the next. But in fact, there's lots of times when you're in the middle of it where it feels a little bit more like this. It just feels like this engine with all this complicated learning going on at once and in a disordered way. And what I hope these sessions give you is a sense to, when you're in a situation like this, which I think is really common, and it's just the way people learn, and it's okay, really being able to kind of go back and identify, okay, what stage are we at? What do we need to doing right now? What role is analytics playing for us right now? How do we sort this out so that we can get to the next milestone? So how does analytics fit into a learning health system? Well, I think that there's kind of two broad ways it supports a learning health system. The first one is just making better decisions. Analytics can help you target the needs with a lot more precision. And good analytics gets more and more precise. There's lots of different ways we can slice a problem, and the better plan we have and the better analytics we have, the more precise we're going to be able to get on what we need to solve. Sometimes analytics escalates the need for action. Sometimes people aren't aware that there is even a problem, and it's not till you actually count something that you know that there's a problem. And then, of course, when we have new interventions and are investing in new ideas, we want to be able to test them. We want to know, is this working? Is it working the way we thought it would work? Is it working as well as we thought it would work? And are there any downstream effects that we didn't expect that we need to pay attention to? Sometimes we'll run multiple tests, like researchers will do this more often than quality improvement folks. You'll run a couple of different programs and see which one seems to work best. And then finally, I think one of the things that helps us with making better decisions is just making mid-course corrections. So you could be moving along and doing really well on a program and then find out, oh, somebody didn't get trained right, or this clinic didn't get all the resources they need, and you understand that because the data are showing you that there's an unevenness in how it's being implemented, and so you can make a mid-course correction. The second big way is I think it feeds our organizational learning more broadly. It provides feedback to implementers about what works and what doesn't work. Sometimes that learning, what works and what doesn't work on one program, can be applied to another program. So it kind of lifts all of our boats when we're learning in a conscious way and making decisions that are very data-driven and data-focused. It helps us refocus as an organization when we sometimes are working on a lot of goals, and sometimes analytics can kind of create some signal from the noise and help us realize where some things might be slipping between the cracks. Certainly helps with accountability. If we have good, reliable data systems and we can know where action is supposed to be happening, it can help us be aware of where things are falling again through the cracks. Understanding the consequences of efforts. I mentioned a couple of times already this need to look at unintended consequences, and analytics can really help with that. And then finally, simply recording the history of an event, of an effort. So sometimes when you do an effort, it's a giant effort, and you don't know really if you're going to use those findings again for anything or what the whole if you're ever going to replicate something like that. But analytics can really help you remember quantitatively, empirically, what you went through, so that if it does come up again or something similar comes up, you can turn to that for guidance on how to plan your next project. So we've talked about there being three kind of major streams of inquiry: research, quality improvement, and program evaluation. And while they have a lot in common, they also have some things that are really different from each other. And sometimes their language is really difficult to wade through. And sometimes people who are trained in one of those disciplines are, very, very firm that this is the right language to use. What I'd like to do is get away from that a little bit and look for those commonalities, because I think for most operational leaders in our organization, those language differences don't help. They really are barriers. So really, kind of where we're approached is giving you, the operational leader, the kind of core methods they need to kind of operate in those three disciplines, and understanding that those three disciplines are going to be interacting all the time in a learning health system, and the operational leader is going to have to be able to navigate those three different fields and get what's best out of all of them, depending on what they're working on. The other thing is that even though there's tons of similarities, it's important to understand that there are key differences as well, and that sometimes you're going to use one of these modes of inquiry with another one, and sometimes you're going to use it alone. And so really understanding, not only how they overlap, but how they're a little different is very, very helpful for the operational lead. So here are some words that I'd like just to replace. I'd like to use the word problem as the thing you want to fix. Researchers frame these as hypotheses, as aims, and they're very connected to research that other researchers around the country or across the globe have done. So they have a kind of language unto their own, and they have very kind of technical ways of framing these problems. And there's a reason for that, and that's good, but sometimes it can get in the way of us just saying, hey, it's a problem in our clinic and we need to think about how to fix it. Quality improvement people tend to call the problem or the opportunity. Program evaluators tend to call it a gap or a need or a goal. So again, these are language differences among these three disciplines that can sometimes really slip us up when really they're really talking about the same thing. What's the thing we need to fix? The second term I'd like to introduce is the term intervention. And this is a term that doesn't belong really to any of these disciplines itself, which I think makes it a little easier. Researchers tend to call it the treatment. Quality improvement people will call it the improvement. Program evaluators will often call it the demonstration, or they'll call it activities or inputs or something like that. But the intervention is the thing that you're going to do to change the thing you want to fix. So the problem is the problem, the intervention is the correction. I think that's the simplest way to think about it. The population of interest, that seems pretty straightforward, but sometimes we call it cohort or sample or population. Again, I think all of these terms have very technical and specific meanings, but I think for most of the work that we do in the hospital at an operational level, it's fine just to use the term population of interest. And then finally, the outcome is the result you want to achieve. Researchers are not afraid of using the word outcome, but they often will speak of it in the context of their hypothesis testing, which again has a very technical and specific purpose, but might trip people up when they're just trying to apply that to a real operational setting. The time is just the time frame in which the intervention occurs, and the setting is that setting where the intervention occurs. But those are handy words to use, and I think, again, trying to get away from how each discipline uses very related concepts, and so that our operational leads can kind of navigate the tools each of those disciplines offer. So this is a little bit of an eye chart, but I want to really talk about it just a couple of minutes to give you a sense of how each of these disciplines fit into our overall attempt to improve, to build knowledge over the long haul. So along the first column, you'll see different characteristics that each of these different fields have. So the first one is traditional research, which would maybe be basic science. I actually have never met a researcher who built knowledge without an intended use, but we tend to think of traditional research as something that it doesn't necessarily have an intended use. So the source of inquiry for a traditional researcher would be research questions that arise from educated curiosity. And the traditional researcher is very proud about not having any kind of judgment about what they learn, not being, and just being very, very unbiased and value-free in how they interpret their data. And then finally, the traditional researcher will really focus on testing hypotheses that are laid out in a very concrete, technical, and specific way. And they want to do that. In order to do that well, they need to do that in a very controlled setting. So sometimes that controlled setting can be created in a lab or a clinic, and sometimes it can't. But the traditional researcher will always try to create a very controlled setting. When we look at traditional research, translational research, program evaluation, and quality improvement, a lot of what the traditional research relies on kind of goes out the window. So first, all of those modes of inquiry focus on building knowledge for specific use in a specific setting. Some more, some less, but generally the focus of all of them is how does this work here and now? The translational research does, when they think about where their questions come from, their questions really will come from other research. But program evaluation and quality improvement, they draw their questions from the local setting. So these are really stakeholders saying, parents, staff, nurses, clinicians saying, hey, we have a problem here, and this is the way this problem works. And program evaluators and quality improvement folks will both kind of take that on, taking kind of a different angle on solving the problem. And then I'm just going to kind of move down and move through this more quickly. I think when each of these look to activities, the activity they actually do, the translational research really wants to look and examine whether the outcomes we got in this clinic for this intervention are what we would have expected them to be based on what's happened in other settings or what's published in the literature. Program evaluation is simply trying to improve the outcomes, kind of look at a delta in whatever you're trying to change. Program evaluators will look at process, but they're really only interested in process as it explains whether or not they've succeeded in achieving their outcomes. So an example of this would be trying to increase the number of children who get the flu vaccine, but not really looking in depth at the processes it takes to build the infrastructure to get to more children vaccinated. Quality improvement folks are kind of just the reverse, and that is they're much more interested in the processes than the outcomes. They are interested in outcomes, but they're much more interested in the processes and understanding how to make incremental improvements in those processes to improve outcomes. So they're, in a way, they're kind of the yin and the yang. So the last thing I want to focus on here is just kind of the scope of where each of these different fields work. So translational research almost always happens in a clinical setting. Program evaluation can kind of happen anywhere, but it tends to be in a broader kind of organization level setting. Sometimes subsystems will be evaluated for program evaluation, but for some complicated theoretical reasons that becomes difficult to do. Quality improvement folks really, really focus on the organization itself or subsystems within the organization, and they even go down to like specific workflows within a clinic. So they each have kind of a different field of focus, but they're all really important in building the learning health system. So just to kind of go through this one more time and think about how each of these asks a different question. The traditional researcher would ask the question that was asked over 100 years ago: could a form of mold cure strep throat? Could we deal with an infection by pulling bacteria from mold? And the translational research, once that question is answered, that has to be answered first, the translational researcher would say, could penicillin treat strep throat in most children if they took it every day for a week? So that's turning from this basic science to really asking the question of how do we get kids with strep throat better? And then the program evaluation would be much more concrete and specific than that even, and it would say, does this clinic screen for strep throat properly and provide penicillin in a timely fashion? So really, are we going to get the outcomes we want once we've decided to provide penicillin? And the quality improvement specialist would say, okay, given that we have we have a screening rate of X% and a treatment rate of X%, how do we improve those? What processes do we have to put in place? What improvements do we need to put in place to improve those screening and treatment rates? So you can see how in a learning health system, you really need all four of these going on at once. Just another kind of view of this, and I'm not going to go into a lot of depth, but each of these not only have a lot in common, but they're also part of the same project of building knowledge over time for the learning health system. And so they help us in each in their different ways, help us build the knowledge we need to make big changes in our learning health system and to make the little micro changes we need to make in order to make those big changes a reality. Just a final emphasis here that the areas that are highlighted in blue tend to be areas that maybe quality improvement people would be most interested in studying, the kinds of questions that they would ask. The areas here highlighted in gray tend to be areas that quality improvement, or I should say program evaluation people, are most interested in asking and what their tools are most suited for. And where you see the crosshatch, that means that those are areas that overlap between the two disciplines. And then finally, the last couple areas that are highlighted tend to be the ones that translational researchers are most interested in answering. But again, we're all really on the same project, and we use a lot of the similar methodologies and a lot of the similar concepts. And it's good to see that because each of those disciplines brings with it different sets of tools, and having a broad set of tools can really help you be more effective at creating interventions that work. So that's what we have for you today. The next session will be focused more on what makes a good intervention and how you begin asking the right questions for a good analytic plan around it. Thanks very much.